Hello, everyone, and welcome to the CoROM Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome back to the program. This is Aebhric O'Kelly. This week, we are with one of the pillars of military, remote, and austere medicine. Dr. Winston de Mello was commanding officer for the BATLS curriculum, the Battlefield Advanced Trauma Life Support for the UK military. That's where we originally met. He has a fellowship from all four of the Royal Colleges. He is, of course, one of the original co-founders of CoROM and a personal friend and mentor. Winston, welcome back to the podcast.
It's lovely to be here, Aebhric, and I just feel very privileged to have this opportunity.
So tell us a bit about yourself and what's keeping you busy.
At the moment, for reasons you know, I keep myself occupied by just doing work on burns, pre-hospital burns, especially the advanced version and the critical care version, and as a trustee of the Vulval Pain Society, which covers the other half of my professional interest, which is pelvic pain.
And you have started the SBLS, the Severe Burn Life Support. Tell us about that.
I think it's about 15 years ago, Ken Dunn, the director of burns at Manchester, where I worked for 20 years, together with Paddy Burke, who's a retired paramedic in Dublin, formed SBLS. Essentially, the foundation was aiming to provide a web-based burn master's degree. I was invited in 2023 to join it. So by Easter this year, I've completed an advanced module of pre-hospital burn care and also a pre-hospital critical care. We're talking about 500 slides in total. And it has a civilian, and as you well know, the JTS burn care has been incorporated on the military version, so that people who want to improve their knowledge on burn care pre-hospitally eventually will be able to learn about it on a web-based premise.
Nice. Maybe we should take a look at that and give that to our master's students and our bachelor students.
Well, certainly the basic course, which is what Paddy has completed, would be ideal for a bachelor's level. Mine, I would say, was at master's level. As you know, for 20 years, I've been teaching on the Masters in Burn Care at the Manchester University. And so the advanced course and the critical care course, both pre-hospital, is at master's level.
And you've done quite a bit for burns and with us and well, actually for me watching you talk about burns since 2009 at the BATLS course. Yeah. You've been pushing burns knowledge and burns education forward. And it's been really amazing to see your impact on the International Burn Committee for Austere Medicine.
Yeah, thank you for that, Aebhric. That's very kind of you to say it. My interest started following the Falklands. We had lots of people that sustained burn injuries. And you remember Phil Ward, another instructor. He and I were junior anaesthetists at the time, and we anaesthetized these burn victims at Woolwich in London on several occasions. And that's how my interest started, because a severe burn injury is a chronic disease. Because if you've sustained a severe burn injury, you're more likely to have cancer, and you're more likely to have an immune-related disorder. In other words, it kills you early.
Wow.
Yeah. So even after the acute phase, things are loaded against you. And burns is only a tiny part of trauma, but burn pathophysiology is so different from trauma. So as a result, very few people have got that experience in burns. And in the military, I'm talking about the US military now because it's been published. The US military have said their military surgeons are unlikely to have a burns experience because of the way surgical training has changed. So basically, burns is becoming less and less focus in the military, and I guess the same applies to the Brits. And unless you have an understanding of what burn injury is, and this is what you have done at CoROM, is bringing it as a method of disseminating information, good information for mature students, really, when you think about it. And I think it's a important thing to do, because very few of us can say, I'm confident of managing a burn. I remember in my last tour in Afghanistan, there was a severe burn injury, and the surgeons asked me for an opinion only because I was the only one who had any burn experience. So that's the reality. And then in the remote areas, in low-income countries, if you can do the basics right, you can avoid potential complications like scarring, like joints being limited in range of movement by good positioning and splinting. So all you're doing at CoROM is targeting the minimum for the most. Do you understand? Getting just the basics right.
So the basics of burn management, which is cool the burn, warm the patient, do mist and fan for 20 minutes to get the burn out of the body, and then you taught me this, put cling film on the burn for the first 6 hours.
Yeah. I mean, a cling film was first published in the 1980s. When you have a burn injury, the injury is not nociceptive. It's also neuropathic. So when you have a severe burn, just the air moving over the burn will cause immense pain. Allodynia, which is a hallmark of burn injury. Now, when you put cling film, not circumferentially, but longitudinally, because you don't want to act it as a tourniquet, you provide a second skin and the allodynia is gone. It's as simple as that.
So by putting cling film on the burn, after it's cooled, of course,
you're
stopping that pain because air isn't hitting those nerve endings.
Yeah, and you're also preventing further contamination, because when you have a burn, the skin is sterile. So by covering it with cling film, you prevent secondary infection. 2, it keeps it moist. 3, it allows the burn surgeon, or in the evacuation chain, an ability to examine the burn without actually taking the dressing down, which is a reason why we discourage the use of topical creams like sulfadiazine that used to be trendy 30, 40 years ago.
And do you allocate removing it after 6 hours due to Pseudomonas?
No. I think 6 hours is a minimum. I think it can be used till they get to a point of surgical care. So yeah, once it's on, it's on. Yeah, you can leave it as long as the logistics require.
So Winston, this came up last week, and your name came up last week. I was invited to be an observer in Linköping, Sweden, as for the ASAC, the Anesthetic and Surgeons Assistance course, and the burns came up it was a live tissue course, so the burns came up, and of course I mentioned cling film on burns, which they hadn't thought about, but I mentioned something else that you're very, very famous for. You were one of the came up with this, which is spraying topical morphine on the burns, and this is now gaining ground because your message, your knowledge, your learning that you've taught us since BATLS time of spraying morphine onto a burn.
Well, it's interesting you mention it because, as you know, for 4 years I was medical director of a hospice where I learned end-of-life care and the use of topical morphine on big wounds, ulcers. So I had learned about the use of topical morphine in a palliative care environment. In 2006, whilst I was working on the burn center in Manchester, a young girl had gone to Israel for a holiday. On her last day, she went to a restaurant and started dancing on top of a table. Her skirt caught fire and she sustained severe burns. She was transferred to our unit in Manchester. And I mean, you're talking about industrial doses of IV morphine. Her pain could not be controlled. So I was asked to come and see her by the burn center. And I explained to the patient, this is what I'm going to do. She just laughed at me. Come on, you've just given me IV morphine and now you're telling me you're going to spray it on my wound? And we did. And it was so effective, we had to give her naloxone to reverse the IV morphine. And it just by coincidence, and I've never been able to quote it because I completely forgot about it. It was actually published as a small letter in 2007. And we've been using topical morphine on the burns units for now, 20 years? But I can now come out of the closet because the Poles have just published a paper this year on topical morphine in burns.
Nice.
I don't have the exact details of it, but so I can come out of the closet and I'll say, yeah, spray morphine. And the thing is, just a word of caution, use water to dilute the morphine, not saline, because saline stings.
Good point. I mean, the morphine would stop the sting eventually, but why be a jerk and put saline onto an open wound?
Yeah. I'm just saying that because when you're dealing with a wide-ranging audience, you've just got to state the bleeding obvious.
Valid point. So I did not know that this came from topical morphine on ulcers.
Oh, yeah. It's ulcers, fungating wounds. Yeah, and also in chronic disease. For example, just take if you got osteoarthritis, let's say it's a knee, you can put in 5 milligrams of morphine intra-articularly and you get pain relief for several weeks. Yeah, because you have morphine receptors all over the body, including the skin, including the joints. In inflammation of a joint, the morphine receptors are activated. So putting in an intra-articular injection, particularly under ultrasound guidance, you can make a big difference to a patient's quality of life.
That's fantastic. And the other thing I remember from burns is ketamine shower. Can you explain to the listener what is a ketamine shower?
Well, I guess the audience that potentially listened to us will probably think of some very, how should I say,
festive and entertaining approach to that?
Exactly. But let's be clear. Procedural sedation is a passion of mine. If you can do a procedure without causing any distress to a patient, I think that's a fantastic ability to have in your armamentarium. Now, if you take a patient, a severe burn patient to theater to do a scrubbing and cleaning and redressing, you're talking about theater time. You're talking about a very expensive way of doing it. Most of the rooms in the individual rooms in our burn center has a shower attached. And the first time I did it was a 60-year-old with 60 burns infected with Pseudomonas. And I explained to her we were going to put her in the shower, and I didn't quite say this, but actually we use a steel brush to sort of clean the wound. But I did it under ketamine cover, so boluses of ketamine. I remember saying to her, look, you might get vivid dreams of sights and sounds and stuff. And after the first episode, so she's a cannula. We can't have any monitoring because you're in the water. And she had another 5 change of dressings under ketamine. Wide awake, talking. First time I used midazolam, and then remaining 4 occasions I didn't even bother with midazolam. So I just keep it simple. And it's so effective. And you know from your own experience how effective ketamine used appropriately. And our mutual friend, Chris Davies, he was the first SF medic in the UK to be licensed to use ketamine. So I think ketamine is underused. I know in third world and lower income countries ketamine is available, but I think people working in the West probably underestimate the potential benefits of ketamine. I mean, our mutual friend Jason Jarvis was using ketamine infusions for depression, for profound depression. So I think it's a great drug. It's just how you use it.
When it first came out, I first heard of it in 2001. I was working as a ER tech in Seattle, and it was only used for pediatrics, and it was so contentious. But thankfully, partially due to your push over the years, it is now more widely accepted.
Yeah, I think it's a great drug, Aebhric, and you've used it yourself. So the thing is that it's all to do with training, isn't it? And that's why CoROM exists, because CoROM fulfills a much needed gap in the training of paramedics. And I think simple things done well. To me, ketamine is a basic drug, and it can be used in so many different ways. It's so versatile. I mean, you wouldn't give morphine to somebody who's critically ill; they'll just drop, collapse just by you showing the ampule. I mean, I can't remember the last time I used morphine in a critically ill patient. I've used fentanyl and ketamine, but never morphine.
Winston, I don't know if you remember this, but the first time that you and I had a conversation it was at BATLS, of course. So you had asked, or the BATLS faculty had asked Dr. Hagman and Deployed Medicine International to supplement your teaching faculty because when 2008, 2009, the op tempo for Afghan deployments was high and you needed faculty. So you had asked for externals to come in. If I remember right, you weren't too happy about us being there. A bunch of, two Yank SF guys coming in and teaching. And I think eventually we grew on you. But I remember the first time you had walked into a room and me and the other SF guy, Mike McCrudden, were in the room. And I think he was watching a video on his phone or something. You were like, well, what are you guys doing? And you look over my shoulder and I was on my laptop and I was designing my first textbook for wilderness first responder. And you were taken aback. I bet you were expecting knuckle dragger mentality from us. And so you looked, and I remember you probably don't remember this, but you said, "Oh, that's fantastic. Can you print me a copy when you have that?" And the next time I came in, like 3 or 4 weeks later, I had a printed copy of this textbook of wilderness first responder, and I gave it to you. And I think you were kind of surprised that a bunch of SF guys could come to put something like that together. Do you remember that?
I remember the situation that you have just described. Just to putting it into context, we had just moved from ABC to CABC, and a lot of the older instructors struggled to make the adjustments from ABC to CABC, okay? So I was appointed a year later as Colonel T.A. Battles as the best of a poor bunch, and as you said, it was extremely busy. We having to do battle courses, and most of the battle instructors were reservists, and they couldn't get time off work. And that's where you came in. Yeah, obviously, I wasn't sure what you were going to deliver, but there was one thing that I remember very clearly. A couple of things, sir. The first is that you were quite aloof. You kept yourself to yourself. But when you, so that's the first thing. And then you also mentioned the fact that you were writing a textbook at the time. I was impressed by that because I thought to myself, "God, this is no ordinary person." But the second thing I remember of that, and I want to quash any thoughts you may have on what our first meeting was like. Your passion for teaching, it was the catastrophic haemorrhage. I think that if I had a video on passionate teaching, it would have been that, your instruction on catastrophic haemorrhage. And I will remember that to my dying day. I just smile when your it's not just the words, your oral presentation, but it's the way you expressed it. Yeah. For all I know, you could have been dealing with a real casualty at the time. You could just shut your eyes and you could see the passion. So I think that my connections with you are very simple because I admire passion. I admire somebody who enjoys what they do, wants to go against the grain, is not stuck by protocols, but always questions. And I would think that to our students, I would say, like Aebhric, be a lifelong learner. That's it.
I want to premise first that at Green Berets, we're not aloof. We're not Navy SEALs. We don't walk into the room and immediately say how amazing we are, and we've got 7 books to our name, and so we're not aloof. We're reserved. We're quiet professionals.
Aloof meaning you're a private person, but when you're like an onion, you peel one layer, you see another. So you're a very complicated onion. Okay.
Yeah, Shrek was right. We are all layers of onions, but So I remember that, and it is passionate because I knew, Winston, it was so humbling to stand in front of 24 people who I knew within a week or two were going to be on the front lines. We're going to be in combat. Yeah. So how profoundly important was this? And so I came up and I spent hours thinking about that CAT-HEM lecture, and I came up with, it took an act of violence to create this wound, and it'll take an act of violence to stop the bleeding. And I wanted that message to get across because I saw these medics, doctors, nurses, not really pushing hard. You had to push half your body weight into this red stuff coming out. and
Yeah.
it's violent. And I came up with that as a way to kind of shock them, get them out of their shell of like, look, this is violence. And that's what we have to do to stop.
And that is why you actually, I could not remember the quote, but I remember the word violent or violence. And that's when I changed my opinions of you. It was,
That's humbling.
It's your passion.
Yeah. It's a need to have that knowledge given to people who will do something with it.
Yeah.
And what's interesting, when I was there 3 years, and it was, I think, if I remember right, somebody came back through for a second deployment, and she said, "Hey, I know you. You were there for my first battles course, and let me tell you that when I first saw my first catastrophic hemorrhage, my words came back to you and saying, hey, push where the red stuff's coming out, and it's violent, and if that saved one life, then I'm walking this planet in a way that's making a difference. And that's why we're here. That's why we are instructors and teachers, Winston.
Yeah, I think you've taken a rather critical view on how, as an instructor, you have an impact on people. But it's even more than that. If you teach one person, that person goes and teaches somebody else, and before you know it, is geometric multiplication, and you reach a bigger audience. Sadly, we don't see that unless, like we are discussing today, we have a chance to sort of appreciate what you've done. So I think there is something nice about being an instructor. It's a responsibility to make sure that students get a good knowledge base. But if you don't have passion and you don't warn people about what's going to happen out there, then I think we're failing our students. And you yourself remember very clearly a few years ago when I went with CoROM to Soma and I did a biopsychosocial impact and talked about death on the battlefield. And you may remember and recall that it didn't go down well. I am pleased to inform you that now we call it end-of-life care or comfort care, which whatever. So I think you have to have passion about what you do, and eventually people will start realizing that what you're talking about. When you look at what we've done at CoROM, my pre-hospital burn care just arose from 20 years of dealing with SF attachments to our burn center. They were asking me questions to which there was no answers. And it was 2016 when Demon Dewing, then a trainee burns and plastic surgeon, actually presented at an international meeting pre-hospital burn management. And it was just dismissed as a non-entity. And here we are now talking about Ukraine and casualty care, and it's there for the taking. So I think sometimes war, especially the sort of large-scale operational events like in Ukraine, so different from Afghanistan. And I think CoROM has been at the right place at the right time to deal with that need. And I think the military need civilian input. And I think that's where CoROM has become successful, because you're providing an unmet need. It's as simple as that.
I think it draws on faculty that have the experience of that and the ability to teach. And you and I don't know if you remember this, in Malta, 2014, we were sitting in the back of the classroom and we watched somebody who was very experienced who didn't know how to teach. And you and I think we pulled him out like halfway through a lecture. And so having the knowledge is important, but having the ability to convey that on to people is not easy. It's so much more difficult to find someone who can teach this to a knuckle dragger than it is to find somebody who's very good at that. So, Winston, you were my mentor. I saw within you from 2009 onward your ability to be excellent as a clinician, but more importantly, to convey that, to teach that, to show that, to be able to push that knowledge onto the next set of hands is stunning. And I learned so much sitting in the back of the classroom, watching you lecture at BATLS. And I was, as a Green Beret, we are instructors. We're force multipliers. I thought I was pretty good. I was wrong. BATLS, I was watching you. I was watching Sue Ackerman. Do you remember her?
Yeah.
She hated us. absolutely despised us. And it was after, I think, a year, I was about ready to start my lecture, and I was waiting for one or two more students. I wandered out the door and looked, and she was coming up, I think with you or Colonel Ward. And she was like, "Oh, I want to hear this lecture because Aebhric is pretty good at what he does." Coming from her was amazing. She was rough around the edges, I'll give you that. But man, could she lecture. And Winston, you brought together a ton of amazing people at BATLS that taught me how to be the instructor I am today.
I smile when you talk about Sue Ackerman, because she was part of the old brigade, and she didn't suffer fools gladly. But if you got a compliment of her, which was rare, you had made it. So I think your recall of Sue Ackerman is well understood, but I think it's a compliment to you that she actually made an effort to attend your lecture, because she had high standards, and she like Phil Ward were instructors, but there were people like Tash Patton. Do you remember Natasha?
Oh yeah,
Patton?
yeah.
And Maxine Bowley. They were.
I just saw her at Soma. I saw her 3 weeks ago, Winston.
Who's that?
Max.
Oh yeah, she's amazing. I've got a lot of time for her, and I went to Tash Patton's wedding 4 years ago in Liverpool.
Nice.
So the instructors, but you had also the more junior in terms of ranks staff like Tash, like Maxine, who kept it going. It's a team effort, isn't it? At the end of the day, and so I just want to pay credit to the support that went into producing the BATLS program, and obviously we needed civilians like you to come in at the time of high tempo. And, whatever you may think, the fact is that you made a difference. And I've just very fond memories of that liaison.
There's another depth, Winston, that I want to acknowledge. And I've not said this to you before, mate, but I learned how to teach, better my ability to teach. But it's more important to that. The next level, which I saw in you emulated this. The next level after teaching is teaching people how to teach. And there's so few people walking the planet who can do that. And Winston, you personify that. I saw you mentor. I mean, every BATLS course, we had all of our faculty in, and we all had to say, we all had to walk, went around the room and had something to say. But your leadership on how to lead was stunning. And I learned from you how important it is. I mean, teaching is great. It's rare. A good instructor is great, but a good instructor who can create good instructors, that is golden. And I really appreciate what I learned from you.
I'm flattered by your comment, Aebhric, but I'm at a stage in my life, in the autumn of my life, and I'm willing to accept any compliment.
Well, I was definitely over my head at BATLS quite quickly, and I saw, and I had to up my game, and I really appreciate that.
Well, let me return a compliment to you. That's where we met, and I remember saying to you, when I finish with the military, I'll join hands with you. And I can remember the the instruction for medical students in Ireland. Do you remember when this girl came out of the bus with multicolored outfits and gumboots, and she asked where the hotel room was, and you pointed to a tent in the field. But that's how we started. I look back and just think, wow. And look where CoROM is now, providing doctorate level education. So, just remember, if you hadn't got the cheek and audacity to do something which I personally thought was next to impossible, you've done it. And I think what I've learned from you is don't give up. Whatever you're facing in life, don't give up. Just every mistake, every failure is a lesson. Don't take it to heart. Just move on. And I think to our students, I would say just be a lifelong learner, because you are an epitome of that drive, of just being curious, keen to improve, and maintaining high standards. So I think our connections over CoROM has been one of great mutual satisfaction. I get a great kick of it. So never forget that.
Agreed. And you have been a profound influence on CoROM faculty and as well as CoROM students. And I remember you were teaching Grigory Tisenovich, weren't you? The Grigory was one of our bachelor students that gave his life in the front lines of Ukraine.
Yeah.
And you mentored him as you have mentored hundreds of other students. And even now, we in our curriculum are things. We have something called the Winston Sign, and this is something you came up with, and we haven't found another name for it. So it's now, like it or not, Winston Sign. It's how to assess somebody's central venous pressure, and you look at the vein in the back of your fist, and as you raise that fist up to where it fills and the vein gets big, or you can start from the top down, that's going to be the level of your central venous pressure. You put a mark on the torso and you mark the date and time, and then that's your trending. So explain to the listener what, because I've completely bollocksed the whole concept, but this is your sign. So tell us about this.
The first thing I want to say, it's not original. I learned it from a South African doctor who worked in the coal mines in South Africa, and using a limb as a manometer. So it's not Winston Sign. I've just learned it from history, but in a remote and osteo environment where you don't have the technology, that's just a simple way of measuring CVP. It's so simple, and you can even use it as a trending observation. So you know whether somebody's deteriorating or not just by the changes of simple observation. And the other thing, which again, when you look at somebody who's not well, is just starting at the feet, moving your hand up the body till you can feel warmth. That gives you an idea as to how the degree of shock is, where the periphery is now being having a reduced blood supply. So yeah, it's making sense of simple observations. So I can't take credit for Winston Signs, but I'm happy to take credit. But I want to make sure that the historical bent is acknowledged. A lot of medicine today, and certainly in paramedical sciences, is not new. And to learn a subject, you need to go back to history. So for me, burns, I've gone back to the original Landbrauder papers, morphine by the U.S. military in the Second World War. So history is important to sort of have a baseline for where we go. And for example, the cling film is a good example. Cling film was published in 1980. You heard it from me in 2000. But the truth is, it was published in the 1980s, and I always go back in history to make sure that I've got my references right. And my colleague Paddy O'Burke published in the Journal of Paramedical Practice a paper on cling film, the use of cling film on the points that we've discussed earlier. But I've always been careful to make sure that when you publish something, you have the appropriate reference to where you got that information from. So I hope the credit you're giving for Winston Sign, sadly, is not original. Okay.
Well, on our publications, and we have 4 different field guides now, it is called Winston Sign. There is no additional reference of where it comes from.
Yeah. Well, send me a photo of that, because I will put it next to my bedside table, and whenever I feel low, I'll just look at it and smile.
And the other thing that we're attributing to yourself is the Palmar creases. So can you explain to us how that works?
Again, even that is not new. You may recall that it's also my original career plan was to be a dermatologist. 8 out of 80 students at medical school became dermatologists because we had a superb teacher in dermatology. And one of the things that is very difficult when you have a burn injury in a patient of color, how do you assess the erythema? That kind of thing. Mm-hmm. So basically, as you get more anemic, the creases become more and more anemic and white in color. So it's a surrogate evidence of, I guess, the hematocrit. It's as simple as that.
So when you hyperextend your palm and the red creases are no longer red, it shows that you have a hematocrit less than 30. Is that right?
It's a poor man's observation.
Well, that is also in our field guides, mate.
Good.
So Winston, another story that I get tickled every time I think about it is you meeting King of Jordan. And I've been to Jordan a number of times. It's a fantastic and very beautiful country, but you met the king. So, and not only that, you treated him. And didn't you bollocks him a bit as well? Didn't you kick him out of your clinic? How did that work?
This is really embarrassing. I had a bit of a cardiac event when I was a regimental medical officer of the Queen's, who we were about to deploy to Belize, and I got chest pains. The next thing I knew, I was PA'd. I mean, I was downgraded, and they swapped me with the cadets medical officer at Sandhurst. So I arrived at Sandhurst as the cadets medical officer, which is basically a mini hospital, and it had a senior medical officer, a families medical officer, and the cadets. So I was in charge of the cadets. And as you know, from your own experience, the cadets at Sandhurst are treated very badly. Badly meaning it's like, it's brutal. And I was doing a sick parade one morning, and I shouted a name. It was clearly an Arabic name. And this guy walks in. He had a incident on the rugby field. I looked at him, examined him, and bedded him down in his barrack room for 48 hours. That was in the morning. At midday, Colonel Bashir Hayes, who's a founder of the College of General Practitioners, an incredible man, came up to my office, knocked on the door, and he said, "I believe you just sent the prince to his barracks." I said, "What prince?" It then transpired that this was the then King Hussein's son, who's now the current king in Jordan. So I was ordered to go to the barracks, pick him up, and bring him to the medical center and bed him down for 48 hours. So it was really funny because there was another patient I must mention at the same time when I was there, and the Women's Royal Army Corps had just been disbanded. So for the first time at Sandhurst, we had female cadets. And another memorable patient was Philida. She had a problem. I referred her to the Cambridge Military Hospital. She saw various specialists. We couldn't make a diagnosis, and she was invalided out. And that was in the mid-1980s. And I've kept in touch with Philida Christmas cards ever since. And it was her sort of meeting her that got me into pelvic pain, essentially. And I've been able to tell her that more recently. But it's interesting, when you went to Jordan, do you remember, to try and get some contracts, and you mentioned the fact that I had treated the then prince. Yeah, life is strange. And I'm embarrassed when you recall the story, because I didn't even I wouldn't know he was a prince. I mean, you just shouted and they turned up, If you told them to do something, they just do it. They just followed every order. But yeah, so that was a rather embarrassing situation.
So Winston, I had a meeting with the physician who is the king's physician in Jordan. He took care of the royal family, and I brought this up. One of my mates, Dr. Winston de Mello, and I asked him to convey that comment to the king if he so sees time. I never heard back, and I guess you haven't heard back either. But it's pretty interesting to hear that story. And another story, you met Dr. Malin Patty.
Okay, this is, you're really making me cringe now. It's a rather interesting story, but it starts off with Archie Brain, Dr. Archie Brain, the inventor of the LMA. He came with the prototype to the Cambridge Military Hospital 2 years before it was launched. And I told Archie Brain that this wouldn't take off. Okay, so that's the first thing. 2 years later, I had the fortune of being the world's first use of the LMA in failed intubation in obstetrics. Wow. So I had a letter published, I think it was the Canadian Journal of Anesthesia, and something else in the British Anesthesia. So in the 1990s, for the difficult airway, my letters came up as a reference. A few years later, I was in Canada, in Toronto, at an anesthetic meeting, and I was in the lobby going around all the exhibits, and there was this Asian guy that kept following me around, and he was doing it in a way that made me feel uncomfortable. It was almost furtive. So eventually, I decided, God, I'm going to confront him. So I walked towards him and said, "Can I help you?" And then I saw his name, Dr. Malampati. And I was so embarrassed. And all he wanted to do was to congratulate me on that failed intubation thing. Oh, if the ground could open up and swallow me, I would have been happy. So that's my relationship with Malampati. So every time when Sunny talks about the Malampati score, I have an internal smile, thinking, yeah, you're the prat that completely misjudged this guy. So that's my...
Wow.
Another embarrassing situation.
It reminds me of a story that John Hagman from DMI would talk about. He said when he was young, he was giving a lecture somewhere and about Trendelenburg, and somebody in the back of the audience was like, "Trendelenburg," and Doc Hagman is like, "Trendelenburg, like, who are you?" "Oh, I'm Dr. Trendelenburg. I made this." Like, everyone mispronounced my name. So but it didn't catch on. We still say Trendelenburg, but there you have it. There you have it. Wow. Winston, your path through life is pretty interesting. And I'm fortunate to have run into you and learn from you and have you as one of my mentors that has made a profound influence in my life. And I really want to say how profoundly grateful I am for you walking the path that you've had on this life.
Well, thank you for your kind remarks. As you know, at this stage in my life, I welcome reminders of certainly my professional career. And I'm grateful to you for inviting me to do this podcast. I find it a great therapy. It's made me smile. It's made me focused on the podcast. I wish CoROM and you and your team all the best for the future. And I hope in the near future, we'll meet again and collaborate on projects again once I get a better situation than I'm in now.
So I always ask a final question, Winston, and I worry about asking you this because that'll be another hour on our podcast, but I would like very much to hear your answer for this. Winston, my final question for you is this. What advice do you have for the new doctor, the new nurse, the new medic, the new paramedic who is just starting out in their career in austere medicine?
A couple of things. Do the basics well, but always in style. What I mean by that is remember that you're looking after a person and that person has feelings. And I know you have done a podcast with one of my medical students who sustained pelvic injuries and the impact the paramedic had on her. So that's the first. The second is learning is lifelong, and just make sure that every day, no matter what happens, whether you're successful or or you have a failure, these are horrible twins. Never give up. Always be passionate. That's my sort of mantra to the next generation of paramedics.
Basics done well. That is a profound statement that everyone really does need to embrace and personify. Winston, I look forward to seeing you the next time we see at a conference, and I appreciate the leadership you've shown in our college as well as in my own academic life. Thank you, sir.
You're welcome, Aebhric. Thank you for the privilege. All the best.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.